Welcome back to the Deep Dive. Today we are taking a deep dive into some pharmacology that really touches everyone everywhere. We're talking about managing, well, two fundamental kind of opposite GI issues, diarrhea and constipation.
Yeah.
Our mission today is pretty simple.
Yeah.
We want to cut through the complex mechanisms of these drug classes and give you a really clear, organized framework.
Yeah.
And we'll focus heavily on what this knowledge means when you're actually providing patient care.
It's a hugely important topic, definitely, especially when you think about the global context. I mean, we often treat these as maybe minor inconveniences here, right?
Right.
But acute diarrhea, it's still a leading cause of death and morbidity in underdeveloped regions. It tragically accounts for something like 5 to 8 million deaths per year, particularly in infants and small children.
Wow.
So managing that fluid and electrolyte loss, it's really a high-stakes clinical task there.
Okay, so before we jump into the specific meds, let's just baseline our vocabulary.
Yeah.
The movement we're constantly trying to regulate pharmacologically is peristalsis, that amazing involuntary sort of wave-like push of food through the GI tract.
Exactly. And when peristalsis is, let's say, moving too fast, we get diarrhea. That's the abnormally frequent passage of loose stools. And we usually differentiate acute, say, 3 days to 2 weeks from chronic, which is more like longer than 3 or 4 weeks.
Okay.
And then when peristalsis kind of stalls out, that's constipation, abnormally infrequent and difficult passage of feces.
And then there's the one that links them both, right? Irritable bowel syndrome, or IBS. That's that recurring thing characterized by bloating, gas, and that really frustrating cycle of alternating between diarrhea and constipation.
Yep, that's the one.
Okay, let's unpack this then. We'll sort of follow the GI tract's flow, maybe starting with how we slam the brakes on the antidiarrheal drugs, and then we'll move on to how we get things moving again.
Sounds good. So the treatment goals for diarrhea, they're pretty intuitive, right? Decrease the frequency, alleviate the cramps, and really crucially, address that fluid and electrolyte depletion.
Makes sense.
But there's a really vital safety distinction here. If the diarrhea is actually associated with a bacterial or parasitic infection, well, giving an antidiarrheal drug is absolutely contraindicated.
Whoa, okay. Why is that such a critical line in the sand? That sounds really important.
Well, because if you slow the bowel down when there's an infection, you're actually prolonging the body's exposure to the organism or the toxin that's causing the problem. The body is, actively trying to expel this invader. We definitely don't want to trap it inside. So if it's infectious, you treat the infection. If it's not infectious, then we can think about slowing transit.
Okay, so figuring out the root cause infectious versus non-infectious, that's like step one.
Yeah.
Absolutely critical.
Exactly.
So when we do decide to intervene pharmacologically, you mentioned these drugs fall into 3 groups, and they often act locally. So they don't quite follow the usual systemic drug rules.
That's generally right. They often exert their main effects right there in the gut. The first group is the adsorbents. Their mechanism, well, the name kind of describes it. They coat the walls of the GI tract.
Okay.
And they chemically bind or adsorb the bacteria or toxin that's causing the issue right to their surface. Then it just gets eliminated with the stool.
Gotcha. And the most famous example here is probably bismuth subsalicylate, right? Like Pepto-Bismol.
That's the one.
Let's pause here, though, because this one, even though you can buy it anywhere, it comes with a major warning. What's the absolute non-negotiable safety concern with bismuth that everyone needs to know?
Right. The key thing is that bismuth subsalicylate is chemically related to aspirin. It's a salicylate. And because of that connection, it absolutely must be used with extreme caution in children and teenagers who are recovering from chickenpox or the flu. And that's because of the risk of Ray's syndrome.
Ray's syndrome. Yeah, it's serious.
It is. It's rare, but it's devastating. It causes swelling in the liver and the brain. So this is absolutely essential patient teaching.
Wow, that really elevates the stakes for what seems like, a simple pink medicine. What about other side effects? More common ones?
Well, the most common effects are usually harmless, but they can be pretty alarming if you're not expecting them.
Yeah.
Like temporary darkening of the tongue and the stool. It looks black.
Okay, good to warn people about that.
Definitely. And more seriously, and this relates back to the aspirin component, it can increase bleeding time or bruising if the patient is also taking blood thinners, like warfarin.
How does that happen?
Well, the bismuth can actually bind up vitamin K in the gut, and vitamin K is essential for clotting, so it interferes with warfarin's effect.
Okay, good interaction to flag. Now, the second group, anti-motility drugs. These are mainly opiates and anticholinergics, right?
Yeah. Correct. Opiates like loperamide and diphenoxylate with atropine, they work primarily by, well, reducing bowel motility, slowing things down. They decrease the transit time through the gut.
And that helps how?
That longer transit time just means water and electrolytes have more time to be absorbed back into the body, which helps firm up the stool. And there's a secondary effect, too. They can relieve rectal spasms and pain.
Okay. And loperamide, that's Imodium AD, right?
Yeah.
That one's over the counter.
Yes, exactly. It's a synthetic opiate, but critically, it's available OTC because physical dependence hasn't really been reported, so it's got a pretty good safety profile for general use.
But then there's diphenoxylate, which is prescription, and it's combined with atropine. That sounds like an interesting combo.
It is, and it's actually a clever bit of pharmaceutical design. It's combined with really small subtherapeutic amounts of atropine, which is an anticholinergic.
But not for the anticholinergic effect itself.
No, not really at normal doses. The atropine is purely there to discourage recreational misuse or abuse. Diphenoxylate itself is related to meperidine, you see, an opioid.
Ah, so the atropine makes it unpleasant if someone takes too much.
Exactly. If someone tries to take large doses to get a high, the atropine dose becomes effective and they get really uncomfortable anticholinergic side effects, severe dry mouth, blurred vision, racing heart, urinary retention. It's a built-in deterrent.
Clever. Okay, and the third class for diarrhea.
The third class is probiotics, sometimes called intestinal flora modifiers. Think lactobacillus cultures, things like that.
How do they work?
Pretty simply, actually. They work by replenishing the normal, healthy bacterial flora in the gut. Antibiotics, for instance, often wipe out these beneficial bacteria.
Right.
So probiotics are fantastic for helping manage antibiotic-induced diarrhea because they help suppress the growth of the diarrhea-causing bacteria. And the great thing is they have practically no listed adverse effects. They're generally very safe.
Okay, good rundown on antidiarrheals. Let's pivot now to the other side of the spectrum, constipation. Now we're talking about laxatives. And here's where you said it gets really interesting, because these are apparently some of the most misused over-the-counter meds out there.
Oh, absolutely. Inappropriate long-term use can definitely lead to dependency and even potentially damage the bowel's natural ability to function.
So it's not just a simple fix then?
No. Constipation is really a symptom. It's not a disease itself. And treatment should always start with the basics. Behavioral and dietary changes. More fiber, more fluids, more activity.
But when pharmacology is needed.
Then we have 5 major groups of laxatives. And they really range quite widely in, how potent they are and their safety profiles.
Okay, let's break them down. Where should we start? Maybe with the safest one.
Good idea. Let's start with the gold standard, really, for long-term use. Bulk-forming laxatives. Things like psyllium, methylcellulose, Metamucil, Citrazole, those brands.
How do they work?
They basically act just like the dietary fiber we should be eating. They absorb water in the intestine, which increases the bulk of the stool. That increased bulk stretches the bowel wall.
And triggers peristalsis.
Exactly. It initiates that reflex movement. They're considered the safest class and generally the only one recommended for long-term use.
Okay, safest. Good to know. But you mentioned administration technique being critical earlier. Especially here.
Yes, absolutely critical with bulk formers. Because they absorb water so rapidly and can swell up, they must be taken immediately after mixing them with a full glass, at least 8 ounces of fluid.
Why immediately? What happens if you don't?
If you let it sit, it starts to thicken and congeal. And if you take it without enough fluid or in dry form, which you should never do, can actually swell up in the throat or esophagus and cause obstruction or choking. It's a serious risk.
Wow. So the teaching has to be super clear. Mix it, drink it fast, maybe follow with more water.
Precisely. Mix and drink immediately. Don't let it sit. That's key teaching.
Okay, class number 2.
Next are the emollient laxatives. This group includes 2 types. Stool softeners, like docusate salts, Colus is a common brand, and lubricants, like mineral oil.
How do they differ?
Well, the softeners, the docusate salts, they work chemically. They lower the surface tension of the stool, which allows water and fat to penetrate into the dry fecal mass, making it softer and easier to pass.
Okay, so they don't stimulate movement, just soften.
Right. And the lubricants, like mineral oil, they work physically. They basically coat the stool and the intestinal lining, preventing water from being absorbed out of the stool back into the intestines.
Oh.
This makes the stool slipperier.
Any catches with mineral oil?
Yes, a caution with mineral oil, especially with chronic use, is that it can decrease the absorption of fat-soluble vitamins. That's A, D, E, and K.
Good to remember. All right, class 3.
Third class, the powerful hyperosmotic laxatives. This includes agents like polyethylene glycol 3350, PEG 3350, Marilax, lactulose, and glycerin suppositories.
Hyperosmotic. So they work with water concentration?
Exactly. They increase the osmotic pressure inside the colon. This draws a large amount of water into the colon lumen, increasing the water content of the stool, causing distension, and promoting evacuation.
PEG 3350, that sounds familiar for like colonoscopy preps.
Yes, it's very potent. It's often used for that total bowel cleansing before procedures. Sometimes requires drinking, 4 liters of the solution over a short period.
4 liters, okay. And you mentioned lactulose. That rings a bell for something else too.
Ah, yes. Lactulose has a really interesting dual role. It's used for constipation, absolutely, but it's also a key treatment for patients with hepatic encephalopathy.
Right, the liver condition complication. How does it help there?
In liver failure, ammonia builds up in the blood, which is toxic to the brain. Lactulose helps to convert ammonia in the gut into a form that can't be absorbed, and it promotes its excretion, so it lowers blood ammonia levels. Really important drug for those patients.
Fascinating. Okay, moving quickly. Class 4.
Fourth class is the saline laxatives. Think magnesium salts like magnesium hydroxide, milk of magnesia, magnesium citrate.
How do these work? Osmosis again?
Yes, similar principle to hyperosmotics, but acting mainly in the small intestine. They increase osmotic pressure there, drawing large amounts of water and electrolytes into the intestinal lumen. This results in a very watery stool, usually quite quickly.
Sounds effective, but any safety flags?
Yes, a key safety point. Because the magnesium can be absorbed systemically to some extent, you need caution in patients with renal insufficiency or kidney failure.
Why is that?
Their impaired kidneys might not be able to excrete the excess magnesium properly, which could lead to hypermagnesemia or magnesium toxicity. That can cause serious problems like muscle weakness, low blood pressure, ECG changes.
Okay, critical check for kidney function there. And finally, the 5th class.
Yeah.
The one associated with dependency.
That's right. The stimulant laxatives. Examples are bisacodyl, Dulcolax, and senna.
Seneca.
Stimulants, so they directly kickstart the bowel. Pretty much. They stimulate the nerves that innervate the intestines, which directly increases peristalsis and fluid secretion into the bowel. They often result in a fairly dramatic evacuation. And yes, these are the ones most likely to cause dependence with chronic use.
Okay. Any special admin notes for these? Like the bisacodyl?
Yes, for bisacodyl tablets, they have an enteric co-coating, so it's best to take them on an empty stomach for faster action. And crucially, the patient should not take them with milk, antacids, or juices, or within 1 hour of taking those things.
Or not?
Because those substances can cause the enteric coating to dissolve too early in the stomach instead of the intestine, leading to stomach irritation or cramping.
Got it. Avoid milk and antacids nearby. Okay, before we shift to IBS, maybe a quick word on those newer drugs for opioid-induced constipation.
Ah, yes, good point. The peripherally acting opioid antagonists, drugs like methylnaltrexone, alvimopan,
Wow, it's a lot
naloxone.
different.
These are quite clever, really. Opioids cause constipation by binding to receptors in the gut. These drugs are designed to block those specific opioid effects only in the bowel cells. They don't cross the blood-brain barrier much, so they don't interfere with the pain relief the opioid is providing systemically.
So they let the bowel work normally, even if someone needs long-term opioids for pain.
Exactly. They're specifically for opioid-induced constipation, often in patients with chronic pain or those receiving palliative care. A very targeted solution.
Makes sense. Okay, so since the GI tract often has, well, both problems, let's pivot now to that chronic condition that kind of alternates between them. IBS, you mentioned treatment depends on the main symptom.
That's right. It really depends on whether the patient primarily has IBS with diarrhea, we call that IBS-D, or IBS with constipation, IBS-C. The approach is different.
Okay, so for IBS-D, what are the options?
Well, there are a few drugs like alosetron, rifaximin, eluxadoline. But let's talk about alosetron specifically. This agent is really reserved strictly for women with severe chronic IBS-D who haven't responded to conventional therapy.
Okay, that reservation. Severe, chronic, women-only, failed other therapy.
That sounds like there must be a significant safety concern.
There absolutely is. Alosetron carries an official FDA black box warning. This is the most serious type of warning. It's regarding potentially severe GI adverse reactions, including the risk of ischemic colitis.
Ischemic colitis. Lack of blood flow to the colon.
Exactly. It's a serious complication. So the critical teaching is, if the patient develops severe constipation or any signs of ischemic colitis like sudden worsening abdominal pain, bloody diarrhea, rectal bleeding, the drug must be stopped immediately and they need to seek medical attention.
Wow. That is a huge risk-benefit discussion to have with a patient. Okay, what about the other side? IBS-C.
For IBS-C, we have drugs like lubiprostone and linaclotide. These work differently, generally by increasing fluid secretion in the intestine to ease constipation.
Any major warnings with those? Like linaclotide.
Yes, linaclotide has an age restriction. It's specifically contraindicated in children younger than 17 years old due to risks identified in animal studies, primarily severe dehydration. Good to know. Okay, so we've covered a ton of pharmacology. Now let's make it really actionable. For the listener who's studying this or applying it, how do we connect this directly to practice through the nursing process? Assessment, implementation, evaluation.
Absolutely. Let's start with assessment. The basics are vital, but there's a procedural point. You must auscultate the abdomen for bowel sounds before you percuss or palpate.
Why that order?
Because manipulating the abdomen first, poking and prodding, can actually stimulate false bowel sounds, making your assessment inaccurate. So listen first. Note if the sounds are hypoactive, less than 6 per minute, normoactive, around 6 to 32 per minute, or hyperactive, more than 32 per minute.
Makes sense. What else is key in assessment?
We absolutely have to prioritize patient vulnerability. Diarrhea, especially in the very young and an older adult, can lead to rapid fluid and electrolyte depletion. So close monitoring of hydration status, things like skin turgor, mucous membranes, urine output, intake-output records, maybe even daily weights is non-negotiable in these groups.
And what about the misuse aspect we talked about with laxatives?
Right. We need to screen for potential misuse. Always tactfully assess pediatric, adolescent, and older adult patients about their use of laxatives. Chronic laxative abuse is unfortunately sometimes associated with eating disorders, or it just becomes a habit, leading to dependency.
Okay, crucial assessment points. Now, implementation and patient teaching. This is where we make it safe.
Exactly. Fluid teaching, as we hammered home with bulk formers, is paramount across the board, really. Even with simple stool softeners like docusate, they need adequate fluid to work well.
So what's the specific advice for docusate?
We generally advise taking the dose with at least 6 ounces of water, plus making sure they're consuming, 6 to 8 additional glasses of water throughout the day. Fluids help almost all these meds work better and safer.
Good rule of thumb. What about teaching for bismuth subsalicylate?
If they're taking the chewable tablets, instruct them to chew thoroughly. If it's the non-chewable liquid or caplet, take it with a full 6 to 8 ounces of water, and you must give that warning about the temporary dark tongue and stool to prevent unnecessary panic.
Right. Manage expectations. And if we're giving meds rectally, like an enema?
Yes, say for a mineral oil or lactulose enema, the technique is key for effectiveness. The patient should ideally be positioned lying on their left side. That helps the fluid distribute into the sigmoid colon due to gravity.
Left side lying. Okay.
And then they need to be instructed to try and retain that enema fluid for about 30 to 60 minutes, if possible, to allow it to work before they try to have a bowel movement.
Got it. Retain for 30 to 60 minutes. And back to alosetron for IBS-D. What's the crucial teaching there?
Patient education is basically the main safety barrier with alosetron. They must understand the black box warning. They need to know exactly what symptoms to report: immediately severe constipation, bloody diarrhea, worsening abdominal pain.
And manage expectations about effectiveness.
Yes, and be aware that it might take time to see improvement. Therapeutic benefit for their severe IBS-D may take up to 4 weeks, so they need patience, but they also need to be vigilant about those serious side effects.
Okay. And finally, evaluation. How do we know if these interventions worked?
Evaluation is fairly straightforward here. We're looking for an improvement in the patient's specific GI symptoms. So, decreased frequency and consistency of diarrhea, or easier passage of softer stools for constipation. We want to see a return to their normal individualized bowel pattern, whatever that may be. And ideally, we'd hear normoactive bowel sounds on reassessment.
Excellent. That was a really comprehensive dive into some absolutely fundamental GI pharmacology. We hit the dual nature of treatments, from potentially life-saving fluid resuscitation for severe diarrhea, especially in vulnerable groups, to the really careful management needed to avoid dependence with things like stimulant laxatives.
Mm-hmm.
And those key warnings really stand out. The Reyes syndrome risk with bismuth, especially in kids, and that serious black box warning on alosetron.
Definitely. And maybe if we connect this back to the bigger picture, given how ingrained the idea can be of just taking a pill for constipation and knowing the significant dependence issues that can arise from long-term laxative use, it makes you think, how critical is the nurse's role?
In what sense?
In really promoting those foundational behavioral and dietary interventions, pushing for increased fiber, adequate fluid intake, regular activity as the true cornerstone of managing chronic constipation, rather than just reaching for the pharmacologic fix first.
That's a great point. Shifting the focus back to the basics whenever possible.
It's definitely something important for you, the listener, to consider as you apply this knowledge in your practice.
Absolutely. Well, thank you so much for taking this deep dive with us today into bowel disorder pharmacology. Really valuable stuff.
My pleasure. Until next time.